so please click on that, and we welcome you this afternoon. Before we get started and I introduce our speakers, just a couple of logistics. If we could go to the next slide, please. We would like you, as I mentioned earlier, to please keep your devices on mute during the presentations. If you have questions, you can submit them in the chat and we'll capture those and share them with our presenters at the end of both of the presentations this afternoon. So without further ado, I'm very pleased this afternoon to welcome Laura Byzadecki, who is the Senior Director for Preparedness and Resilience at the National Association of County and City Health Officials, or NACCHO. She has over 25 years experience working in multiple sectors in public health. In her current role, Laura manages NACCHO's portfolio of preparedness programs, supporting the nation's nearly 3,000 local health departments' preparedness, response, and recovery initiatives. After Laura's presentation, we'll hear from Bruce Evans, who is the fire chief at the Upper Pine River Fire Protection District in Colorado. Having previously served as the EMS chief at the North Las Vegas Fire Department and at the Henderson, Nevada Fire Department as a fire and EMS captain for 18 years. All told, Bruce has over 37 years of experience in EMS settings and is currently the president of the National Association of Emergency Medical Technicians. So I will stop now and turn the platform over to Laura. Laura, thank you so much for being with us today.
Megan, thank you very much for having me. I really appreciate the opportunity to speak to you today. You can go to the next slide. I'm going to spend a little time today talking about a little bit about NACCHO as a whole, then talk about some of the preparedness portfolio's history with some projects that we've dealt with regarding the aging population, and then spend a lot of time talking about a tool that we developed recently with the Assistant Secretary for Preparedness and Response that is all about how to plan for, respond to, and recover from all hazard events. And then if you want, we can spend a little time talking about what NACCHO's been doing in response to the current pandemic. So as Megan mentioned, NACCHO is the voice and catalyst for the nearly 3,000 local health departments across the country. And it's our mission to best serve our members through education, advocacy, and convening. So next slide, please. We do all of this within our core values of equity and excellence, participation, respect, leadership, science, and innovation. Next slide, please. And again, our work revolves around advocacy, partnerships, funding, training, education, network, resource tools, and technical assistance. A majority of our funding is actually received by CDC. So we do a lot of work in partnership with CDC. However, we do have some additional projects. And the work later on that I'll be speaking about was primarily funded with the Assistant Secretary for Preparedness and Response. Our training and education component, my team, the preparedness team, actually does run the largest meeting of governmental public health officials related to preparedness summit. And through that, there is a lot of work and ongoing advancement of the science through presentations at the preparedness summit, which happens every year in April sometime. Next slide. So a little bit of the background of NACCHO's preparedness portfolio. We have within our CDC programs, something called Project Public Health Ready, which is actually a recognition and it's a recognition kind of accreditation program that actually looks to and recognizes local health departments through a series of criteria as being ready. And they recognize them for 5-year stints. And it really is kind of a accreditation, training, and quality improvement program. So it really is measuring Do they have the plans? Do they test their plans? Do they train to their plans? And are they truly ready according to certain metrics developed by both NACCHO, CDC, and our members? We have a series of work groups and committees that always advise our team on what we're doing and how to best support our work. And then we have some communication. So we have a variety of communication channels that we use to distribute information to our members. Our AFPHS projects include the Medical Reserve Corps. And I don't know if y'all know anything about the Medical Reserve Corps here. It's a tremendous network of volunteers that has been supporting response capacity at the local level for about 15 years or more, since I think the original Pandemic and All Hazards Preparedness Act was out there. We support the AFPHS Hospital Preparedness Program through healthcare coalitions. Sure, Bruce can speak a little bit about that as well. And the National Health Security Strategy, which is kind of the umbrella under which a lot of the preparedness programs fall at the state and local level. It is the guiding light for where all the other programs, governmental programs, including CDC's preparedness, public health emergency preparedness program fall. We've also done work with them on cyber supply chain and cybersecurity. And finally, but most importantly for this call, we talk a lot about disability and inclusion projects with them. And again, as I mentioned, the Preparedness Summit. Next slide. So a little bit about the specifics. And some of these programs are still going on. From 2015 to 2019, NACCHO has been supporting the Empower project with AFPHS. Now, Empower is, it's a mapping program. It's a publicly available interactive tool that is really overlays Medicaid data, Medicare data. And for those electricity dependent folks, of which we find that a number of them are in the elderly subset, it helps to identify where to get the power up quicker. So health departments are using this in their risk analysis as well as their planning efforts to help them make sure that they are getting the power up to those who are most in need of it. We also, about in 2015, developed a directory of organizations that are serving older adults. And it's a big checklist to say that if you are developing plans in your community, these are the groups that you really do need to have some outreach in order to make sure that you're being comprehensive in your planning. And then in 2016 and 2017, we did do some post-Hurricane Sandy work that was really looking at how wraparound community and home-based services really help to support quick recovery after Sandy, and what are the lessons learned in Sandy, and how we could use that to develop additional planning tools. Next slide. Oops, I don't know what happened to this one. Sorry, we can go on to the next one. I think that one was, sorry for that. I think that one was, we also worked with CDC on a project that was really talking about aging registries, which at the time seemed like a good idea, but as our programs evolved, we realized that aging registries may not be the best place to put resources at this time, as they are not always effective and rely on a lot of other things to be truly effective. So now let me spend a bigger chunk of time talking about the capacity building toolkit, its purpose, goals, and kind of what each module wants to talk about. I really try to see it as what we think is truly helpful to local communities and probably those in your cohort. So the purpose of this tool is really the capacity building toolkit for aging and Disability Networks and Emergency Planning is to serve as a resource guide for the aging and disability networks in increasing their ability to plan for and respond to public health emergencies and disasters. For those organizations already engaged in emergency planning, this toolkit is supposed to help improve and expand their capabilities. For organizations new to emergency planning, this toolkit will help them orient them to the process. As I said, the primary audience for this toolkit is organizations within the aging and disability networks that receive funding from HHS Administration on Community and Living. Most of those provide advocacy and/or programs to older adults and people with disabilities. It also can be helpful to emergency planners and public health officials to help them to understand the capabilities and expertise of community-based organizations within their aging and disability networks, and how to welcome their partnership in emergency planning activities in the community. I want to go back. Can you jump to the next slide, please? So the toolkit is comprised of two sections. Section 1 addresses assessments and emergency planning, and Section 2 addresses working in tandem with consumers to address a range of considerations that arise before, during, and then after an emergency. The toolkit itself also contains supplemental tools and suggested resources that are included in each module. It also contains a glossary of terms at the back, and within the document, modules and other resources are hyperlinked to help make it easier for folks to identify resources and quickly get to resources and tools. Overall, the approach that we use to develop this guide is one that is a whole of community approach to planning, which ensures that communities are better prepared when they engage the capacity of the private and not-for-profit sectors and other communities partners to work together to address the needs of those with access and functional needs. It wants you to include residents, emergency management, public health, organizational and community leaders, governmental officials, to promote a collective and holistic understanding of the communities and population's risk, and how to use the whole of community approach to determine the best ways to organize excuse me, and strengthen assets, capacities, and interests. Implementing the whole of community approach to emergency planning should include all the community-based organizations that serve older adults and people with disabilities, be they direct service providers, consumers, or advocates. So now I'm going to go through each of the 9 modules, and this may seem a little redundant, but I just wanted to go through it with you so you can see all the different pieces and why this is such a broad-based tool that will help you in doing your emergency planning, response, and recovery efforts. So module 1 focuses on early planning and includes information on the CMIS framework, how to conduct readiness assessments and metrics, and how to identify community partners, and how there are other tools and exercises to help you forge relationships. Module 2 focuses on preparedness planning and includes how to create an emergency plan, how to define roles and emergencies in a plan, understanding incident command systems and national response framework, and how to test plans and exercises. Module 3 is about how to prepare for public health emergency and talks about maintaining situational awareness, understanding, and how to understand all hazard threats, be they natural, infectious disease, or human. I think we can go to the next slide. Yeah, thank you. Section 4 is module 4 is really about how to identify older adults and people with disabilities in your communities? And how do you define and quantify that population? What are the federal sources of data, including national data sets like Empower that we talked about earlier? How you might go about data mapping and providing support for the development of consumer personal plans and addressing emergency housing needs for older adults. Module 5 is about effective messaging for older adults and those with disabilities, including how to reach them technically through various channels, and how to develop both cultural and linguistic competency. Module 6 describes how you and your organization can be involved in emergency and evacuation planning. Module 7 is about sheltering and housing, including identifying where there are shelters and housing options, and getting the individuals ready for moving and any issues related to ADA compliance. Module 8 is on legal issues for consumers that has a whole range of all of the existing federal legislation, what it means, and then helps to identify where you might be able to identify legal support and legal expert support from other CBOs in your community. And then finally, Module 9 is on recovery, and including assessing the financial impact, any FEMA support that could be received, and how to address the emotional impact on both the community and the individual health workers. So that's a listing, that's a description of the current tools that NACCHO has available, specifically related to preparedness and response. NACCHO has a number of other tools that might be available to support the aging population. We've just done another tool through another project on how to prevent falls. And all of that is available on NACCHO's toolkit. And if you have any questions on how to directly access that, I'd be happy to identify that. In addition, and I thought when I was reviewing the slides, I might add this, NACCHO and currently maintains an incident command structure within NACCHO that is daily responding to the issues of COVID. Every day, we've been in response mode now since February 2019, I guess, or even 2020. I get confused even sometimes how long it's been. I guess it's February 2020. But I've been thinking about COVID from even before that. And so we have been primarily, I think for the first 6 months, truly in response mode. What do our members need? What is defining constant situational awareness? As time goes on, we've just kind of moved into a structure that is really focused on sustainability of response and how we are integrating COVID response throughout every program throughout NACCHO. So from our legal team to our chronic health teams to our infrastructure team, which talks about how to better structure health departments. COVID is integrated into every piece of the work that we do. And we have a number of other COVID related projects that are helping to support COVID response throughout NACCHO. We don't have any specific programs related to the elderly population, but that's not to say in the future that the lessons learned, excuse me, won't be applied, and we might look at our existing tools and modules a little bit different and develop additional training. We are offering a lot of mini grants to our health departments. One of the more prominent ones is to help identify lessons learned for rural and frontier communities and what they need in terms of workforce to better identify and meet the needs of their consumers. And so we are looking at providing direct training and technical assistance, including some of the risk communication efforts that we talked about earlier. And so we are looking to do a phase 2 of that project as well. And so I'm happy to share information about that program if you live in a rural frontier community and need support, and particularly workforce support from your health department related to this population. You might want to reach out and suggest that they apply. There's increasing number of projects that are coming out all the time. And so again, thank you for this opportunity to speak with you today. And I'm happy to answer any questions. Hopefully I'll be able to answer. If not, I'll find somebody who can.
Great. Thank you, Laura, so much. I jotted down a number of questions. So if we don't get to them all, I'll probably put them in an email and send them to you for a response. So thank you so much. And so I think we'll go ahead and move on to Bruce, and then we'll take all the questions toward the end. Okay, so Bruce, we will turn the platform now over to you. Thank you for being here.
All right, can everybody hear me okay? Okay, great. So I'm, like Megan said, I'm Bruce Evans. I'm the current president of the National Association of EMTs, and I'm a fire chief in one of these super rural areas, or what we would consider frontier areas. So I appreciate everybody's time today, taking time away from work to pop on a webinar like this. What I'm going to go over is just kind of a little bit of a case study on how we operated a super rural vaccine clinic as a rural fire protection district. So if I could have next slide, please. So just a little bit about the Upper Pine River Fire Protection District. We cover 272 square miles of territory in Southwest Colorado. We have about 33 employees, most of them all vaccinated by the end of December in 2020. We have about 8 paramedics on staff, about 25 EMTs. Most of them are trained to do IVs. In the state of Colorado, it's another 24-hour module on your EMT training to become an IV tech. Again, super rural population of about 12,000 people in the 272 square miles. We generally have a fairly conservative tilt of folks in our fire protection district. A few years ago, it was kind of a Tea Party hotbed. So a fair amount of, as you can imagine, vaccine hesitancy here. We became a 1A vaccinator through the state on January 9th of 2021. This occurred after about a month of shadowing the regional medical center staff that was operating hospital clinic. And I think, as everybody's aware, when we started rolling out the vaccine for hospital workers, especially ICU nurses and doctors, we went over and put our staff at the hospital and shadowed the staff, the nursing staff that was doing the vaccine administration. Now, I would tell you also that was also instrumental in getting our own people vaccinated, because as there were holes in the schedule or there were extra doses drawn, we immediately filled those with firefighters and paramedics. So we were approved as a vaccinator by our state health department and our local health department on January 9th. We did our first clinic on January 10th. Our first clinic, we asked for health district supervision. So we had, for about 2 hours, the health district vaccination team kind of here watching what our firefighters and EMTs and paramedics were doing with the vaccine administration. Next slide, please. So again, it's kind of an interesting path about how we got into this. So again, why and how did we do this in a rural fire protection district? The first thing I would tell you that my role is that at the National Association of EMTs, which is about 80,000 strong, representing EMTs and paramedics around the country. I am the representative to the National Academy of Medicine. And I would tell you, the National Academy of Medicine hosted a briefing in February of 2020 on the COVID-19 pandemic. As typical of the National Academies of Sciences, we had excellent presenters. And although I've been involved in that organization for 16 years, I walked away from that briefing essentially terrified. And we've dealt with a lot of specific things there. I think, the folks that have belonged to NACHO, that Jack has been your representative there, and that there's ongoing representatives from public health on our committee of preparedness there. So when I left that briefing, I had a full grasp that this was going to be a nationwide and global pandemic, and that it was going to be a public health emergency. I think that was still something that was still a little bit hard for people to understand, is that this was going to be an all hands incident. So we ramped up immediately in early February with training for our paramedics and EMTs on personal protective clothing, how to get in and out of a PAPR, how to approach patients that may be infected, how to minimize the exposures to crews that are working in somebody's home. Now, I would also tell you that we had built a very good relationship through our healthcare coalition, the Southwest Healthcare Coalition here in the Four Corners. So we had been participating for over 5 years in the healthcare coalition. So we had built a lot of strong relationships with our local health department. They knew who we were, we knew who they were. They trusted us. And again, they knew that we showed up and understood the public health message and the public health mission. So we are already a provider in the National Ambulance Strike Team contract. So FEMA has one phone call they make to a company called Global Medical Response when there's a need for, say, hurricane deployment and ambulances to move patients from nursing homes or hospitals or supplement a 911 system. So we have been participating in FEMA's National Ambulance Strike Team program as a rural agency. And again, we only have 3 ambulances, but we have an extra one that we can send to Florida, Louisiana, Texas. And as a super rural agency, my staff would not be able to see these large scale disasters without participating in that program. So we've been to Florida, we've been to Louisiana, we've been to Texas. So again, a little bit of experience with disaster response that we gleaned from other states. So we began doing COVID testing for the health department as one of their outreach organizations. So again, the east side of La Plata County, we became the testing folks. As you can see here, we did an assembly line process in the picture above. We advertised on our Facebook page, and we had iPads where we were directly putting test results and enrolling testing folks into the health district's database. We started that in early September of 2019, or 2020. So we also formed a local incident management team with our school district, the health department, our local law enforcement, and the towns and cities that we cover. So we were routinely meeting every Wednesday, just kind of doing a situational analysis on what was going on with COVID and what the current situation was. Also included in that local incident management team was the library staff. I like to tell people you have a great community if you have a good fire department, you have a good library. So we had acquired a vaccine fridge from the health department through the Healthcare Coalition years before COVID showed up. Now, we had that beefed up as we decided to move into the vaccine role. We had it serviced, we had it certified, all part of the requirements to the state before you can become a 1A vaccinator. We also did some emergency generator tests to make sure that we had backup power on that. So if we were storing vaccine in it and the power went out in the middle of the night from a snowstorm or a lightning strike, that we wouldn't lose any vaccine. We had also deployed an ambulance to Del Rio, Texas as part of the FEMA team for 30 days in October for a COVID surge down there. And much of the kind of operational experience that the crew got while they were in Del Rio, transferring COVID patients into San Antonio, we brought back some lessons learned and applied those to our organization. When the vaccine became available, we immediately went over and started shadowing the RNs and the vaccine staff at our local hospital and supplementing their efforts. The fire district, we were able to apply staff to this because it is really kind of our downtime. So it really didn't cost us any additional, impact to our service. We also got very good about drawing up and helping with the vaccines from the standpoint of, and many of you know that have administered vaccines, it takes a little bit of skill to get those extra doses out of the Moderna or the Pfizer vials. So after drawing hundreds of vaccines, we had firefighters and EMTs that got that very precise 0.5 cc's out of those vials. So we also started in with helping our local health department with their incident action plans. As was previously mentioned, operationalizing some of these big operations is somewhat of a skill. We do this for wildfires all the time. We do it for other disasters. So we helped with the incident action plan and putting some pods up and following the hospital incident command system and showing them where they can make modifications into that to establish public health clinics to do vaccinations and testing. So we took responsibility for our zip code so that we could track the patients in our zip code. We're also following this and billing Medicare. So we obtained a separate PTAN, and I know a lot of people are getting vaccines for free, which it's great. The vaccines are free and provided by the federal government, but Medicare was paying healthcare providers to administer the vaccine. And as a little agency that only has a $4.2 million budget, every bit counts. So we were, people volunteered their Medicare cards. We tracked it, got a PTAN and submitted for billing on it. Our first Cool Cube showed up, as I mentioned, at 6:30 a.m. on the January 9th of 2021. It had 200 Moderna in it. And we went immediately to town, starting in on vaccinating the 70 plus folks. Since then, we've gotten so good at doing our vaccinations and organizing this. The state of Colorado has given us a contract effective March 1 of 2021 to go out and do equity clinics and help kind of take the vaccine the last mile out to some very remote areas, which our folks are very good at doing. We have since supported vaccine clinics for migrant workers. We actually have a crew over at the homeless camp today, helping vaccinate the homeless. So again, a lot of experience and again, a lot of interaction with our health department. Next slide, please. So we created an assembly line process, and you can see this here. It was kind of an all hands event. The picture you see up in the upper left corner is typically what we do for most wildland fires and large scale incidents. We do a team briefing. It's part of the planning process for those ICS purists that are on the call. We also had parking assistants and greeters. Many of you that may have vaccinated the 70 plus folks, you know that it's not an easy turn to get in a parking stall. It's a backup, go forward, back up again, go forward, maybe a couple more times. So very, risky moving the 70 pluses in and out of our parking lot. We also had a check-in and check-out system. We were actually putting our data from our vaccines directly into the Colorado SIS system so that we weren't just sending paper up to the state where they had to duplicate the efforts. We trained our staff, got logins so that we could reduce the burden of paperwork on the state office. We did do safety checks routinely. And you can see the crews here going over their safety profiles. And then we moved into a bunch of monitoring and training of our staff as they went through it. You can see one of the EMTs drawing vaccine up in the upper left corner there. Then you can see our really high-tech vaccine timer. So again, knowing that the vaccine has to sit out and warm up when you bring it out of the fridge, we placed a little ladybug timer on it before we started drawing from it. And then we brought people in one entrance and sent them out a separate entrance so they didn't have to pass by people to try to reduce the exposures. And then, like I said, assembly line process, getting through about 100 to 200 people a day, again, in a very small rural community of only about 2,000 people. Next slide, please. So we had our 70 pluses that were in our zip code with their first shots completed by January 29th. I like this photo here because it has 3 generations of war vets. The guy in the middle holding that walker is a World War II vet. He was a pilot on a B-17 or a navigator on a B-17. There's a Korean War vet to his left and then a Vietnam War vet to his right. Again, we got about 100 to 200 people through our administration building in this assembly line process. And you can see the team that was able to get the 70 pluses done here. Next slide, please. We had our teachers completely vaccinated by February 11th. So we got through the 70 pluses fairly rapidly. And even though our governor hadn't cleared the vaccine to go to our teachers, we started about a week early on them because they were organized. We let the health department know that we were kind of jumping the gun a little bit, but we had vaccine in the fridge and we wanted to get the shots in the arm so we could order more. So we just kept the vaccine order coming. We ordered every week and we made sure we could get as many in the arms as we could. Again, our vaccine fridge was a health department hand-me-down that I have to credit the Healthcare Coalition in getting for us, because again, had we not been at those meetings, we wouldn't have known that fridge was available. They wouldn't have offered it to us, so it was a big deal. So we did teachers and wildland firefighters. We focused on the wildland aviation assets. As many of you know, we're in the throes of wildland fire season now. We didn't want helicopter pilots and the pilots that dropped the retardant on wildland fires down with COVID in the height of wildland season. So we jumped ahead and did them too. Although first responders were a priority, we wanted to make sure that we got our wildland firefighters and our aviation assets included in there. Next slide, please. So as I mentioned, we got our state contract on March 1st, and we immediately started in with some equity clinics. We've been all over the 4 corners. The picture that you see in the upper left there is one of our firefighters vaccinating somebody in a low-income housing project. We also supported 2 clinics to tribal governments. So we were out on tribal property twice with clinics, helping with vaccinators and medical standby. We also went in and did some low-wage employees. So we did the restaurant industry. We actually showed up to some of the restaurants and they did a group vaccination. As many of you may know, here in Durango, Colorado, we have a tourist train. We showed up at the tourist train's headquarters and vaccinated all their employees that are service industry employees that service that train, so that we could get our vacation economy back open. We also did several large clinics in RV parks and campgrounds. And we experienced something what I call vaccine tourism. Once people knew we were getting the vaccine out, we had people come up and stay in our campgrounds from Texas, Oklahoma, New Mexico, even had some people come from San Diego. They made their address the camping spot in the local RV park. We cleared this with our state health department, and our state medical director was under the opinion that the federal government was providing these vaccines. So let's just get them in the arm of anybody who shows up. So again, we operationalized that very quickly, and we took advantage of the, again, what we would call vaccine tourism. Next slide, please. So as I mentioned to you, we did some Fema deployments too. We sent our vaccinators out all over the country. So Upper Pine personnel were in Edison, New Jersey for almost 4 months. I sent a paramedic there on a 30-day rotation to the Edison Convention Center, where they were vaccinating hundreds of thousands, even thousands of people every day. We sent 2 teams, 3 firefighters to Memphis, Tennessee, to assist with a vaccine clinic there. And then another group of firefighters for a 30-day assignment into Memphis. Again, this is a slow season for us. Again, our call volume really picks up during tourism season in the summer. So we had a lot of extra personnel, so it didn't really impact our local service. We did intermittently shut down one 2-person station in one of our tourist areas that, again, was not really experiencing a high call volume. And then you see one of the photos here where our folks were good enough at the vaccine drawing and administering. They put a Marine a medical unit into Memphis, and it was Upper Pine folks that trained them how to administer the vaccines. Next slide, please. So what are the results? So we're fairly lucky. La Plata County, I think we're just looking at our stats yesterday, we're at about 74% fully vaccinated here, where I think we're the 4th or 5th highest in the state of Colorado now. We had a very low death rate. Most of our deaths were in the one nursing home that kind of was slow to get on and slow to accept the monoclonal antibody therapies, and of course had a huge population at risk. We never overloaded our ICU here. With our local hospitals, it got close, but never in a situation where we were putting patients in the hallway or running out of ventilators or running out of nursing staff. We had a very low death rate here. And again, most of them affiliated with one nursing home that kind of slipped through the planning cracks and the therapy cracks. We've probably administered now over 7,000 doses. I probably liken that to almost 8,000 doses now with state equity clinics. We've only had one serious event out of all the vaccines we've administered. We do spot check our folks and we call our local people. We usually have a team that calls and just says, hey, how you doing? You experienced any side effects? We had one person that had a platelet crisis that had to be flown out of Southwest Colorado to Phoenix, but I would tell you she did really well. She actually drove her car back with her family 2 days later after getting a platelet transfusion. We saw no anaphylaxis. And we saw a lot of people getting emotional after their vaccine and started to hyperventilate. That was maybe could easily be mistaken for an anaphylaxis or an allergic reaction event. We did see some local reactions and had applied a fair amount of Benadryl cream to people that had localized reactions. Next slide, please. So again, a pretty successful rural clinic. Just real quickly to finish this up, a couple of lessons learned here. One thing that we definitely realized is we have a lot of 70+ people that live in the wildland urban interface. And from a planning standpoint, these are folks that would have to be evacuated. And then watching, as I mentioned to you, that they don't pull into a parking stall very well. So you can imagine that it's probably pretty difficult for them to get in their car and evacuate during a wildland fire. So this forced us into some new considerations for evacuations. And also knowing that many of these people are at home during the quarantine and during the isolation that a lot of folks were experiencing during the height of the COVID outbreak, that people that might normally be at work or at school were at home, and that this was going to complicate a lot of 2-lane highways that would evacuate certain neighborhoods. So this was kind of a little bit of a tangent with our vaccine clinics, but it was a big wake-up call for our evacuation process. So we did have a power outage with our fridge. And again, you got to plan for that. I think it's important to test your generators, make sure that all of your circuits that these vaccine fridges are on or critical pieces of equipment are on, including radio systems, are all isolated. A lot of times, with the electrical demands of many of our facilities these days, sometimes our generator loads can't take all of the electrical requirements in a facility. So it might be a procedure or process to shut down some of your other equipment that is non-essential to make sure that you can preserve the power load for your fridges and your other critical equipment. Again, a lot of cross-pollination from techniques that were being done at other FEMA sites in Memphis and Edison and Del Rio. So it was really good to blend our staff in with those other staff members that were conducting vaccine clinics. The medical standby, like I mentioned, we gave some Benadryl and some Benadryl cream. It did not really have any true allergic reactions or anaphylaxis. We did have a lot of emotions. I was shocked at the number of people after they got their first shot, just that drop in anxiety. We had a lot of people leaving our facility in tears, tears of joy. The guy that you see being vaccinated here in the lower picture is actually the former president of the American Medical Association. He's a retired trauma surgeon from Santa Monica, California. He was first in line in the 70 plus to come in, and was happy to lend his voice as a champion for vaccines. The other guy you see up there in the blue shirt and the mask with you can probably barely make out his logo, but he is from Napa in our auto parts store. Now in a rural, super rural community, the Napa person is the auto parts people are the go-to people. Everybody knows him. This guy's on the front desk there. So him getting his vaccine kind of helped with some of the people that are more conservative that would have been hesitant to get a vaccine. And this, he became a vaccine champion for us. So again, a lot of folks that were on the conservative tilt and certainly on the anti-vaxxer or the vaccine hesitancy tilt, once they saw him get a vaccine, they had a chance to interact with him at the front counter at the auto parts store, they signed up to come in and get vaccinated. Next slide, please. So another critical lesson learned is I can't stress enough the value of the healthcare coalitions and how our relationships with our local health department was absolutely critical in making sure that we were able to pull this off. There's a trust factor there. There's a competency factor there. There is just a familiarization. There's an understanding of how the process works and who to call, who to talk to. Again, this was very critical prior to the event. And again, we've been participating in the Healthcare Coalition for 5 or 6 years now with our leadership on the steering committee and participating in all the events that they do. So again, I can't stress enough the value of a solid healthcare coalition that has EMS involvement in it, which again, by their charter, they should have an EMS representative there. Vaccine and other equipment acquired prior to the event. We're the only building on the whole east side of the county that has an emergency power. Many years before COVID showed up, we had a local pharmacy here who lost power for a whole day. They called us to see if we could house some of their temperature sensitive drugs because we have an emergency power generator, and we were able to do that. So we'd had a few run-ups to actually having to have a reliable refrigeration. Again, we shadowed the early adopter. We were early adopters of the process by shadowing our local hospital. They were kind enough to let us in and give us privileges in their vaccine clinics that were being done in the local hospital. We have a can-do medical director. We're a little unusual as an EMS agency. We don't have an emergency room physician as our medical director. We have a surgeon. And she's a little spitfire. She's from Nebraska. She has a great work ethic. She has just a can-do attitude. Our state medical director for EMS, Dr. Beckman, also has a can-do attitude. And the local health department's medical director, because of that relationship with our medical director, he put his faith in us and trusted us. So medical direction, having a can-do medical director, absolutely critical. And then we have great operations people that do a great job with wildland fires and other disasters. And there's one thing to do is get the policy wonks out of the way and let the operations people operationalize things. And that is a huge lesson. There are people that are really good at operationalizing things. And then there's a lot of other folks that want to overanalyze stuff. And we're very fortunate that our health department trusted us to operationalize these things, and we went to town on it. Just remember that EMS and fire is a force multiplier for public health. That's probably the biggest takeaway from this. EMS definitely realizes that we have a public health role. We are not the policy people. We are not the people to direct policy or direct initiatives, but we have the personnel, and we have the logistics, and we have the community reach to help public health achieve their mission. I would also say the healthcare coalitions have traditionally focused on resources coming from a rural environment into the bigger centers in an urban area. And, you know, we also need to take into consideration two-way traffic on this. So a lot of rural agencies that had excess resources certainly were available to go into the metropolitan areas and help with the overload. Again, hence we were in Edison, New Jersey, again, an urban area. We were also in Memphis, Tennessee, again, a heavily populated urban area. As their resources got overloaded, there are rural agencies out there standing by to help, but traditionally the flow of patients, say for example, a stroke or a critical trauma, comes out of a rural area and then typically gets moved into an urban area. Well, in this particular case, there were rural resources that could have supplemented their urban centers. So while the healthcare coalitions a lot of times focus on patient movement inward to the urban areas, just take a consideration that you might have some resources that can also go in with that. And the vaccine administration closed the stress loophole over the pandemic. A lot of EMS crews have been seeing some catastrophic outcomes with people with COVID, you know, a lot of cardiac arrest, dropping people off at the ER, and then an hour later they're gone. And it has been a huge emotional toll on healthcare workers, as I'm sure everybody on this call is aware of. Putting a shot in somebody's arm is just about as significant as a cardiac arrest save. And I think that is absolutely critical that you're able to close the loophole on this. And again, because it was the fire district doing the vaccines here, we overcame a lot of vaccine hesitancy. We are a trusted organization in our community. So again, the people that were somewhat hesitant on vaccines, they had firefighters and paramedics explaining to them the mechanism of how the vaccines work. We never pressured anybody, we never scared anybody, but we were here to serve them. And that definitely made a huge difference for us. Next slide, please. So again, a few other lessons learned. Again, excellent relationships between the medical directors. We had great mentoring from our health department. They were here and checked everything, and we welcomed them to double check us. In one of those photos there, you see one of the health department people doing our fit testing for us. And again, EMS knows it has a role in injury prevention and disease prevention, and that we are there to complement public health. We had equipment and training in place. Again, our people know how to be in and out of PPE. They're in and out of it all the time for fires, other infectious patients. One of the things you see there is some specialty equipment that we employed, which was the UV lighting. So we secured UV lights early on in the pandemic. And we were routinely going around and disinfecting like our jails, some of the schools. So if they had an exposure where they knew they had a confirmed COVID patient that might have infected the environment, we loaned out our UV lights to help disinfect people in the neighborhood. So again, we're a trusted resource. We're a force multiplier for public health. Next slide, please. So again, just to kind of summarize the final, purpose for all this is, again, we took pictures of every SHOT team that was in there just to commemorate the fact that hopefully this is the only pandemic we see in our lifetime, but probably not. And again, this putting a shot in somebody's arm is just as significant as having a cardiac arrest save. It was one more person that was hopefully prevented from being on a ventilator and having a bad outcome. So again, thanks for your time, everybody. Happy to answer any questions. Megan, if we have any in the chat that I can address, or any of the other questions, feel free to contact me, and Megan and the rest of the folks have my my contact information. So if there's somebody that needs it more, has any other questions or in-depthly wants to talk about it, I'm happy to be available for it. So again, thank you for your time today.
Bruce, thank you so much. And Laura as well. Yeah, two things that just kind of struck me was the last statement you made, that a shot in the arm is just as significant as a save from a cardiac event. That had not been put in perspective for me before. So I appreciate that. And also, I had not seen the sharing of the UV light apparatus. That's the first that I've heard of that. That way of like connecting with the community as well. So Bruce, there is one question in the chat about suggestions around different people's vaccine hesitancy. So I know that you have addressed hesitancy just in terms of being a trusted source, but there are lots of different reasons for hesitancy. And so I wonder if you could go just a little bit deeper on how you all work through that.
Right. So I would tell you, as the fire chief and as, having a very significant science background, I sat with people and spent a tremendous amount of time with folks explaining to them how the vaccine works, and dispelling a lot of the issues with, sterilization and, the Bill Gates bots. I mean, and it took just a lot of one-on-one conversation with folks. The other thing I would tell you is that we never pressured anybody. There were probably 2 or 3 people during this whole process that said, you know what, I changed my mind. And we said, hey, we're here when you decide that you want to get it. Mm-hmm. We understand completely. And again, we never pressured anybody. We never shamed anybody. And that lighter touch, I think, just saying, we're here for you if you need it. I think also having those champions in other folks in the community. I would tell you that we have probably 24 very grumpy ranchers that were very skeptical of the vaccine. All of them came in and got vaccinated.
Wow. Wow.
And again, it was a lot because it was who was doing the vaccines. They trusted us to do it. People that came through our assembly line process had, even the ones that hyperventilated and got real emotional, they saw that we took care of them very quickly. So I think people trusted us that if something was going to happen with the vaccine, that we were right on top of it. Yeah. So that quick medical response for anything that would happen in the waiting area was also instrumental. And then I would tell you that I've talked to several conservative folks that are vaccine hesitant. And, I'm a big believer that as more and more of these variants emerge, I hope and I pray that we don't get to the position where one of these variants negates all of the vaccine efforts that we've been doing. Mm-hmm. As I was telling Megan before the call started, we have 142 breakthrough cases here in La Plata County that are fully vaccinated people. About 40% of those are immunocompromised folks. So, there's a message here that the next variant, whether it's Lambda or Omega, or whatever the next alphabet letter is that we're going to name it, it might be something completely different. And if you ask virologists, how many variants does it take before you have a completely new virus? And then all the vaccines that we've done are going to be negated, and we're going to have a new disease that we're going to have to deal with. Nobody can tell you that. It's incredibly random. But what we do need to make sure that we tell people, and again, this is for the conservative crowd, do you really want to stand by and watch your government flush $4 billion down the toilet in vaccine efforts? If you're really conservative and you're a conservative fiscal person, realize that there's a lot of effort going out to this. And if people don't get vaccinated, and one of these variants slips through and becomes something different and waste all that money, do you really want to be party to that? Believe it or not, that sells to some people. And then the other thing is just, if you want to get back to, maybe you have a relative that is immunocompromised. Maybe it's your kids now that are getting the Delta variant. So I would tell you that, we're still out doing equity clinics. We're still out doing vaccine clinics. It's trickled down to 1, 2, 3 people at a time. But we're trying to get every one of them. And again, realizing that there might be other alternatives for them at some point. And then, the reason that we're vaccinating people. And from a fire district standpoint, why we're telling people that we're vaccinating, other than we're trying to make sure we get this done before another variant emerges, is that we don't want to see you in the back of our ambulance. Okay. And if we can put a shot in your arm and you don't have to go by ambulance for a 911 call when you get short of breath from this disease, that's an important piece. And then the other thing that I've shared with folks, back to the financial piece, is I had one firefighter that picked up COVID outside of work. He was hospitalized for 6 days at a cost of $66,000.
Oh my.
And he was not on a ventilator, but he got remdesivir for 5 days. He's a very healthy, fit individual, 38 years old. And again, a $66,000 hospital bill for 6 days in the hospital. And, this is a free vaccine right now.
Mhm.
And, if you think your health insurance deductible is okay and you're good with paying a high deductible, or even if you're on Medicare and you're having to pay the 20%, if that's easy cash that you can throw down, then, okay, pass on the vaccine maybe. But if it's not, and it's going to medically bankrupt you, then maybe you should consider taking the vaccine while it's free. Because it won't always be free, in my opinion. I think at some point, this will become much like tetanus and everything else. It'll cost you $25 here or there. So yeah, the financial piece, and if you're on a ventilator in an intensive care unit and you're lucky enough to get off of it, that's an exorbitant hospital cost. And again, most people that's going to medically bankrupt. And just again, from the financial health standpoint of your life, consider taking a vaccine.
Right. And I think that the financial aspect of it is an argument or a discussion that not a lot of people have thought about. So thank you for bringing that up. We are a little bit over time here. I did have some questions for Laura. I know she has a hard stop and has to hop off. So we will, Laura, I will share my additional questions for you. Bruce, I have a couple more for you too. And we will get those answers from you all and share those hopefully with the audience at a later time. Karan, if you could go to the last slide, I just want to do a quick plug for our next training in September, where we will focus on ways that public health can collaborate with other sectors and other organizations to promote healthy aging. And please register for that under at afphs.org under events. Thank you all so much. Really excellent presentations today. Laura and Bruce, thank you for all the work that you're doing. Thanks everyone for all that you're doing in the field, and we will see you again in about a month. Thanks everyone.
Thanks, everybody.